the large lesion. Okay. Oh my God. Okay, how's it going? Good? All right, brain is full. It's gonna explode? All right. Okay, so, all right, so we're gonna talk about a couple of other things. So temperature control versus power control. Okay, so temperature control is the modality we use with non-irrigated catheters because we know that the temperature can, rise. We know that the tip temperature is going to correlate with the tissue temperature, so we can set that to a limit over 50. And the power goes up and down based on the temperature feedback. So if the temperature gets too high, the power will titrate down, et cetera. And it'll shut off if an impedance limit is exceeded. And this is the usual mode for non-irrigated RF. Power control is when the power remains constant. That's what we're used to with irrigated catheters. You set a power and then that's it. And you'll shut off only if the temperature or the impedance goes too high. All right, so electrode tissue contact, you get higher current density with greater contact. Current density is proportional to the square of the distance from the ablation electrode. This is just an example of, lesion depth when we're looking at contact force. And you can see that the lesion depth is higher with higher contact force, both in the RV and in the LV. So just to summarize what we've learned so far, so we've said that current density is critical for creating an effective lesion. Electrode size, power settings, and electrode tissue contact are important. Let's talk briefly about duration of energy application and impedance. So duration of energy application, this is a non-irrigated catheter. At some point, there's diminishing returns out to 500 seconds. So don't stay on that long. And it seems like we sort of reach our limit at 60 seconds, okay? What about impedance? This allows us to appreciate Georg Ohm, okay, Ohm's law. So V equals IR, or I equals V over R. So the current and resistance are inversely proportional, right? So if the resistance through your circuit is too high, what's gonna happen to the current? The current is gonna go down, right? So in theory, if you can decrease the tissue impedance, then you can increase current delivery. So how do you improve tissue impedance? Well, tissue impedance is basically the human, right? And then getting to that dispersive electrode. If you add another patch, right, you have more dispersion, less resistance, okay? Has anyone ever done that before? If you look at the impedance, like you go on RF and like the generator is not happy because the impedance is too high, right? And that is the sound it makes. So what you can do is, if you're like our hospital that went to smaller electrode patches, you add a second, which kind of, obviates the point of getting smaller patches that are less expensive. But anyway, if you put on 2, then you decrease the impedance and then you can move on, okay? So you can use additional electrodes or larger electrodes. You can reposition the dispersive electrode. No one does this, but in theory, if you move that closer to the ablation electrode, you can decrease the tissue impedance. Half normal saline. So how many, does anyone use half normal saline? Okay, so you can use half normal saline. So how does that work? How does that, in theory, improve the lesion size? You do that because you want to deliver a larger lesion, right? So how does that work? Well, it turns out that there are fewer ions, right, flowing through your irrigant tissue. So relatively speaking, the tissue becomes lower impedance, okay? And so the current is going to tend to flow to the relatively lower impedance tissue, and you can theoretically get a larger lesion. All right, this is a nice graph just showing that if you put 2 patches on, like in green, you can increase your current delivery, okay? All right. So fascinating. Okay, so let's talk a second about the dispersive patch because this is really important. If you measure body temperature, so this is our person and the ablation electrode. If you measure body temperature at the ablation tip, it's very high. At the dispersive electrode, where all the electrons are flowing and you're generating some current here, it also comes up a little bit, okay? It's a little warm, but because there's not high current density, it's low current density, right? Because you have a large electrode through which you're dispersing that, the temperature is relatively low. However, you can imagine a scenario where you have poor contact, right? you have poor contact or your dispersive electrode is too small, then that current, right, concentrates at that one spot. And this is how we get the dreaded skin burn. Okay, has anyone ever seen this before? Yeah. So this is suboptimal. If you see through your, when you're delivering ablation, your impedance is very high. First of all, you won't be able to deliver radio frequency, but your goal is really to make sure that that indifferent electrode has good contact. And if the impedance is high, that may be an issue. Okay, question number 3. Which factors can lead to skin burn from the indifferent electrode grounding patch? Small size patch, incomplete contact, excessively high impedance, or all of the above? I only have 10 minutes and 34 seconds left. Okay, I got to barrel through. Okay, so the answer is, and maybe people change their minds or not, the answer is all of the above. Yes, okay, great. Okay, so what determines current density? All these things we just talked about. However, there are limits to power and force, right? So just like there's overheating, you can overpower, you can overforce. So this is open irrigated RF catheter on a canine thigh muscle preparation. And basically the point is that here's 30 watts versus 50 watts, 30 watts versus 50 watts with increasing contact force. And you can see that the incidence of thrombus formation, your overheating, is high. And then the incidence of steam pop, is also high. So just understand that there is a sweet spot, okay? That's what I want to tell you. So there's a sweet spot. You need minimum force, okay? So Mahmoud and I were like trying to ablate the roof outside the right superior pulmonary veins, and we kept like, it's just like this, and like we were never quite tall enough, and then it would shoot up to 40. It was really alarming. But anyway, so we kept going from here to here to here to here. If you're always here, no matter how high your power is, you're just not going to deliver an effective lesion. So you need to have sort of minimal force, but not too high. If you're over 30, a lot of the time, studies have shown you're more likely to perf. And then power delivery, if you're going to go high power, your duration should be relatively short. Okay, there's all sorts of ways of assessing effectiveness of lesions, temperature achieved, so you want to get to that 50 degrees Celsius. Electrogram diminution is nice. Loss of pacing capture, generator impedance drop, all sorts of indices to follow. That's its own talk. Okay. All right, I have 8 minutes to go through cryoablation and pulsed electric fields. We will do it. Okay, so cryoablation, I just have 3 slides, okay, so it's gonna be, okay. So it's all about this thing called the Joule-Thomson effect. So James Joule, we know, and Thomson is actually Lord Kelvin. All right, so it's basically the concept is change in temperature of an expanding gas, okay, of an expanding gas. Okay, so how does that work? So liquefied gas, okay, how many people do cryoballoon ablation? Anyone? Yes, everyone? Almost, okay, so have you felt the tube delivering the gas, when you're doing cryoablation? And it's like really freaking cold, okay, and it's cold for a reason, okay, it's delivering this liquefied gas, okay, nitrous oxide under constant pressure, and it's passed from a small chamber into an expansion chamber, okay? And that liquefied gas, as it expands, actually absorbs heat, okay? So it's removing heat, and that's ultimately what causes the freezing. And it does it in this fashion, in this, this is sort of a diagram of that. In the central chamber, the liquefied gas is being delivered, and then it expands, in this expansion chamber, and you get, number 3, the catheter adheres to the tissue. You get freezing, which causes cellular dehydration, then ice formation. And then it's actually the thawing part that causes the cell membrane rupture and ischemic injury. Ideally, you're adhered for at least 2 minutes, and you reach about negative 40 degrees to ensure irreversible cell death. This is a nice, I think I'm going to skip. And basically there's also conductive cooling during cryo. And there is sort of a difference in sort of the nature of cryo versus RF lesions, and you'll see the pulsed electric field ablation lesions are also a little bit different. There isn't this same sort of hemorrhagic characteristic to the lesion. Okay. All right, pulsed electric field. So how many people feel like they kind of understand pulsed electric field ablation? Sort of, okay, all right. Same here, okay. So let's talk about it. So what do we know? There are things we don't know, I will say, about pulsed electric fields, but in terms of the concept, okay, in the 1980s, people thought, well, why don't we try intracardiac defibrillation? And so they would deliver 200 to 360 joules of energy through a small electrode. Okay, talk about current density, okay? There was gas formation, there was arcing, there were explosions, pressure waves that formed and vessel rupture, and there was a melted footprint on the electrode. So this turned out probably not to be quite the right protocol for this technology. In 2007, though, the technology was refined, and it was shown that epicardial pulse field ablation was effective in isolating the appendages. This is a very early study then in 2011 looking at pulmonary vein isolation, which is the application we're looking at today. So how does it work? So you guys are probably familiar with reversible electroporation, right? So that's performed all the time, right? To deliver drugs, right? To deliver proteins and nucleic acids into cells by transiently opening pores, letting those go in, and then those pores close up, okay? So this is just, pulsed electric fields is just sort of along that continuum of delivering sort of more energy and causing irreversible poration. And how is that done? Basically, the idea is to create an electric field near the tissue of interest. You don't necessarily need direct contact, although a closer contact is better. An electric current is delivered in a pulsed fashion, and I'll show you what that looks like in just a second. High energy for irreversibility, and it's delivered in a synchronized fashion. That seems sensible. Okay, so what happens exactly? So this picture explains it all, okay? So basically you get an electric field, okay? And there is then pore formation. These 10 nanometer pores form, and you get water molecules sort of moving along the gradient of that electric field, and they reinforce the pore. And if you give enough energy for long enough, those pores become irreversible in formation. And then you can imagine, the cells have, fluid and ions flowing through, in and out, and they basically just can't take it anymore, and they just die. Okay, so that's how pulsed electric fields work. What do the waveforms look like? Who knows? Each company has their own proprietary protocol, and they can vary any of these, 7 variables. And it's almost infinite, the protocols you can apply. So here's one example: over 20 milliseconds, 500 volt, pulses being delivered. And one full cycle with 500 and a negative 500, is delivered over, 500 microseconds. So it just depends. And unfortunately, there isn't a lot of data from the individual, companies to tell us exactly what's happening. But in any case, basically it's a short pulse duration. How many people have seen pulsed electric field ablation performed? You guys have seen it, okay. Resistive heating quickly dissipates, so it's really non-thermal. There seems to be tissue selectivity, with cardiomyocytes having low threshold values for irreversible electroporation, higher thresholds in collateral structures, which is pretty great. This may be a function of cell size, the impulse waveform. There does seem to be an absence of coagulative necrosis, and this is a nice picture of the fibrotic lesion at 3 months, which is transmural. Other features, there are some downsides. So the high voltage current can cause electrolysis and gas formation. You can see bubbles on ice form. There can be myocardial stunning, so that there is electrical injury that is reversible, but we're blind to it at the moment. It can mask poor tissue contact and discontinuous lesions. Currently, there's not really power titration. Who knows what the power is? And it does create large lesions. There are a lot of unanswered questions with pulsed electric fields. What is the long-term durability of lesions? What do the microbubbles mean? And then there is this issue of coronary vasospasm. With 1 minute and 15 seconds left, I will conclude, potentially early. All right, so the goal, just to wrap it all together, that was like 1,000 concepts in 40 minutes. My college mentor would be upset. The goal is to form permanent electrically inert lesions without causing collateral injury. So with radiofrequency, your goal is to optimize current density, okay? Electrode size is important, power delivery, electrode tissue contact, duration of energy application, and impedance, as we discussed. Cryoablation is nice that it maintains tissue architecture, and your goal is to optimize tissue contact. And pulsed electric fields are promising. They appear to have a differential effect on different tissues, but optimal protocols and lesion durability are still TBD. 18 seconds left. All right, thank you.
Questions, Dr. Kim?
Yes. Yeah.
Avoid the esophagus. What do you change? What parameters do you change? Your contact force? Do you change your duration? Do you change your power? What do you like to do for that?
Yeah, that's a great question. So actually, Mahmoud and I did this yesterday a lot. I opt for high power, short duration. In theory, it's a shallower lesion. You get more resistive heating and less conductive heating, so less deep of a lesion. I'll definitely make it shorter, and then I avoid, on the ridge or maybe on the, in front of the right side of veins, I'll go for big contact force, but I will shy away and try to stay closer to kind of like 10, 12, not really go over 15.
We have a virtual audience, and there was a question in the chat, so I'll ask you, if you have a high impedance, say you're in the coronary sinus and you can't deliver too much power because of the impedance cutoff, the question is, what if you increase that impedance cutoff? What would happen?
Explosion.
Yeah, yeah.
Yeah, the impedance cutoff is there. Yeah, the impedance, cutoff is there for a reason. So, yeah.
And with a very high impedance, the current's very low. So you might get a lot of heating, but you're not going to get much current in. So you better be right on whatever you're going to ablate. Better be right on it, and it can't be much under where you might get it by raising it, but you're probably you're not going to be able to deliver much current at all.
You're a small lesion.
Any other questions?
Okay, so our next speaker is Dr. Brad Knight, ablation of paroxysmal AFib, evidence and approved technologies.
Okay, good morning. Thanks again for being here. I know there's some new faces compared to yesterday. There's a little bit of overlap with my presentation compared to yesterday. I have a few opening comments to make. One is that the soccer game starts at 9 o'clock, and although Andre and I debated the pros and cons of soccer versus American football, which I have a bias toward, you're welcome to check the score periodically. Number two, I'm not nearly as animated as Susan Kim this early in the morning. She gets up and gets on the Peloton at like 5 o'clock in the morning. I'm just getting coffee in me, and I can't really move in the morning. So with that, my topic is ablation of paroxysmal atrial fibrillation, and we're going to talk about approved technologies. Unlike Susan's talk of ablation, biophysics, I'm not going to talk about pulse field ablation. We're going to talk about what we're currently doing and the data to support what we're doing. These are my disclosures. And I'll start with a story. When I came to Chicago 20 years ago, I met some neighbors, the McGinleys. They were parents of kids that went to school with my kids, and the guy said, "Oh, you're a cardiologist. You probably would want to meet my wife's uncle, who's going to be in town this weekend." I'm like, "Yeah, probably would. It'd be kind of interesting." So I go to their house, and there's this guy, he's probably 70 years old, sitting on a picnic table with these two little kids eating macaroni and cheese off of a paper plate, and it was Eugene Braunwald. And so, now he's still active at, I think, something like 90 years old. So I'm bringing this up because this was a paper that he wrote when I was a fellow Cardiovascular medicine at the turn of the millennium, triumphs, concerns, and opportunity, and this guy really had a lot of insight. He declared that there would be two new epidemics of cardiovascular disease emerging. One was heart failure, and one is atrial fibrillation. So back in the 90s, a lot of or at least in the 80s and 90s, it was about large myocardial infarctions, inotropes, development of cardiac defibrillation, development of CCUs and ways to keep these people alive. But these are the new epidemics that are mainly related to aging and keeping these patients alive in a long term. In addition to heart failure, the number of hospital discharges for AFib more than doubled from about 100,000 in 1984 to 270,000 in 1994. That number now is over about 500,000. This is worrisome because patients with this arrhythmia are at risk for embolic stroke and heart failure, two conditions associated with early death. With the aging of the baby boomer cohort, the prevalence of age-related arrhythmias will only increase further. So that's really telling from 1997. And to put things in perspective, we talk about the COVID pandemic. I would say that there's an epidemic of atrial fibrillation. Every week I look at our procedure board, and every week it's becoming more and more dominated by AF procedures. And fortunately, we have, I think, some good mix where we're doing other things and SVT ablations, et cetera. But the amount of AF procedures really has taken off, and so has atrial fibrillation. So I looked at the data for the COVID pandemic, and there was an approximately, based on this summer, the 7-day daily average for August this summer was 5,690 per day. In atrial fibrillation, approximately, there are this many AF hospitalizations per year. There's about 2,000. So if you look at the COVID pandemic, over a third of those numbers are patients being admitted for atrial fibrillation. So it's still a big problem. At least there's been some emphasis, I think, recently. These are the European guidelines on prevention. I think appropriately there's a lot of emphasis on upstream prevention of atrial fibrillation by treating hypertension, obesity, alcohol consumption, and some of the things that we can modify for atrial fibrillation. We're going to focus on what we tend to do, which is to try to treat the atrial fibrillation with non-pharmacological options, patients who have failed medical therapy. And we're going to talk about catheter ablation for paroxysmal AFib. This is a part of a slide from an anatomical study looking at the muscle sleeves of the pulmonary vein tissue. And it shows the right upper, right lower, left inferior. And it shows you a few things. These tissue islands that go up and extend into the pulmonary vein are variable in length. There's little islands of tissue, and it's a perfect substrate. If you wanted to create substrate for reentry, this is how you would do it. There's also evidence that there's triggered activity coming from here. And it also shows how the lower veins or the inferior veins tend to have shorter muscle sleeves than the upper veins. You know, in the early studies, this was 20 years ago, you know, the Bordeaux group showed in 1998 that the pulmonary veins were a trigger for a lot of patients with AFib, in particular patients who had no significant structural heart disease. And this is what we would see. We put a circular, there was no lasso when they were doing this. They developed kind of this circular mapping catheter to put in the pulmonary veins. And when you do that, you start realizing that these premature atrial beats that you see on the surface start really much earlier than you see the P wave, and usually from a pulmonary vein. And you can electrically isolate that vein. Initially, it was a very ostial ablation. We now do a more antral ablation. And occasionally, you can still get this, even with cryo. You'll see pulmonary vein fibrillation. The vein's fibrillating, and there's exit block, and the patient's in sinus rhythm. So this is kind of the physiology that kind of led to this whole empiric 4-vein, pulmonary vein isolation in patients. Because at the beginning, we were only doing patients who had episodes of AFib in the lab. So you see some patients in clinic, you still see some of these, who on the rhythm strip, they'll have AFib for 2 seconds, sinus rhythm, AFib, sinus rhythm. And it is those patients that taught us that the pulmonary veins were the source, and we started by just targeting those patients and ultimately came up with this empiric approach, because most patients come to the lab either persistently in AFib or they come to the lab and they're in sinus rhythm. And yes, you can look for triggers and you can give isoprel, but it's rare that you have the patients like we had before that were spontaneously going in and out of it. And you know what has happened over time? This is a plot it's really just relatively speaking, but there are patients who have no symptoms, and there's patients who are highly symptomatic, and every time they go on AFib, they end up in the ER. There are patients who have very low AFib burdens, and over time, we know that these patients can progress to longstanding persistent AFib. In our initial efforts, we're targeting these patients who were very symptomatic with paroxysmal AFib. But that only represents a relatively small portion of the overall problem. In the next few years, we started targeting persistent atrial fibrillation, again, though, mainly focusing on patients who are symptomatic. And I think now we're really expanding this to patients who are both earlier in the phase of their atrial fibrillation, so very early onset. Some arguments can be made for first-line therapy for AF ablation, and then patients who have longstanding persistent atrial fibrillation, or even patients who seem to be less symptomatic but may have heart failure or other things that may improve over the long term by maintaining sinus rhythm. So right now there are two general approaches. I think a couple of people raised their hand about laser balloon. That is an FDA-approved device. There are surgical approaches. There's the convergent approach. But when we go into the EP lab with catheters and we're going to isolate the vein, there are two basic approaches. One is point-by-point focal ablation, and there's cryoballoon. And as I tried to argue yesterday, I think point-by-point ablation is inherently limited by gaps potentially forming, leading to pulmonary vein reconnection. And if you have more than one gap, allowing reentry to occur in that territory, giving you pulmonary vein-dependent atrial flutters after an attempted PV isolation procedure. Things are much better. We have irrigated catheters, we have contact force, we know a lot more about the biophysics, and I think high-power short duration has greatly improved this approach. But the cryoballoon, I think, is a logical way to isolate the veins. I showed this yesterday. You know, this is the concept of point-by-point durable ablation. This was actually a while ago, before we even had irrigated catheters. This was with a 4-millimeter tip. And this is an animal where we had PV isolation electrically, and when you open the heart and look at the lesions, you can see that there's the potential to form reconnection through some of these areas that are gaps and not overlapping lesions. So I just put this slide in yesterday because I just did this patient last week. So it's a 58-year-old man with paroxysmal AFib 3 years ago, not 20 years ago, 3 years ago, when we had all these great tools. He underwent an ablation with radiofrequency, and immediately after the procedure, he had AFib, and he says, I never got any better. I've just been continuing to have this. I'm now on antiarrhythmic drugs. And he was hesitant to have another procedure, obviously, because he never seemed to benefit from the first one. And this was at a reputable center by a reputable electrophysiologist. So it's not like this is an inexperienced operator with old tools. This is modern PV isolation with RF. And all 4 pulmonary veins were reconnected. And it's interesting because you can kind of see where these lesions were made. You can see an antral lesion set was probably made here around the right side of veins, and around here around the left side of veins. And our approach often in these cases, unless you can really find a few gaps, is to put a cryoballoon in there and freeze the veins, which is what we did. And it's only been a week, but the patient's done well. We went through the step-by-step approach of how to use cryo. We don't have time to go through really procedural details, but we have learned a lot more from imaging. We had the opportunity to use real-time 3D ICE during some EP procedures, and these are just some images of the 2D images and 3D images of a cryoballoon ablation. So you'll see this now when you do, for example, left atrial appendage closure, and you have a TEE, you can get a 3D image of the closure device. This is a 3D image from the right atrium of the cryoballoon, occluding the left superior pulmonary vein. And here's a nice example of a leak. And then I think this will play here. This is when the balloon has deflated once it's reached 20 degrees, and this frozen contrast and blood coming into the left atrium around the balloon. So the imaging that we have now is significantly better as well, but we tend to do this all with ICE guidance. So this is a freeze showing you that even in patients with atrial fibrillation, I tend to cardiovert most patients. usually before I start to isolate the veins, I think it's a little easier to detect pulmonary vein isolation. There's also the very rare scenario where you isolate the vein and you can't tell because the vein is fibrillating and the atrium's fibrillating. And although that's quite rare, you would be able to identify that when the patient's in sinus rhythm. And now we've interestingly created exit block during the freeze in the left superior pulmonary vein, and then developed complete block. And as we continued to freeze, it terminated. And it tells you a few things. One, that when you freeze or isolate the pulmonary veins, you electrically disconnect them, and that may be what terminates the AFib. So there's this back and forth. The AFib drives the pulmonary vein drives the atrium, and you have this cycle, this vicious cycle of each driving each other. Once you isolate the vein, it could terminate. This may also be termination because of freezing that got to the GPs, or this is a vagal reason for termination. It may be that the freezing extended up to the focus that was causing the AFib in the pulmonary vein. So it still is some interesting physiology. We use the cryoballoon, as I mentioned, for some redo cases. This is another example of a 44-year-old man with coronary disease, refractory PAF. He had had 3 PVIs with RF by 2 different electrophysiologists. He came back and both inferior veins were reconnected. You can see he's in fibrillation at the time. The circular mapping catheter shows entrance into the pulmonary veins, and with freezing these veins, we were able to re-isolate them. So the tool is useful for first-time PVI, but it's also a useful tool, I think, for redo PVIs, and we've published some papers on using it for PV-dependent left atrial flutters. It can also be used for challenging anatomies. We routinely get pre-procedural imaging. I think it's helpful. I showed a case yesterday where there was a true right middle vein that we had to put the balloon in to isolate the right-sided veins. We will use the balloon even in patients who have a common ostium. We use ice and tend to target the roof and the floor, and then sometimes anterior and posterior. But in a vast majority of cases, the left common ostium can also be isolated with a cryoballoon without occlusive lesions. And I do find it helpful to have that information up front. I think having pre-procedural imaging. If not, a pulmonary venogram would show that. Or honestly, if you don't do pre-procedural imaging and you look on ice, you can very quickly identify this as a common ostium. So this is what we love to see. This is the goal. Here's a lady with a pacemaker who had a pretty high burden of atrial fibrillation, and at this moment had a cryoballoon pulmonary vein isolation, came back 6 months later, and she has, this is an old slide, but this patient continues to do well. She has no atrial fibrillation. So we use in all these clinical trials and FDA approval trials, time to recurrence. That's the way drug studies were done. And ablation technologies are still evaluated based on time to recurrence because that's a reproducible comparative way for the companies and FDA and investigators to compare new tools. But that's really not what you want to know. Clinically, a patient can have AFib every day. You do an ablation. 3 months later, they have an episode for 2 minutes that's documented. That's considered a failure, and they're often much better off. So we are starting to more and more look at AFib burden, but the trials that have looked at time to recurrence include the Fire and Ice trial, which I'll talk about, and then this was the Stop AFib post-approval trial, which I showed yesterday. It showed that in the real-world population, with over 340 patients at 3 months, freedom from all atrial arrhythmias was 64%. We looked at, tried to get a sense of how patients did clinically and looked at the redo rate, and the freedom from redo ablation was 80%. So although some of these patients are failures, many of them were not having enough atrial fibrillation, or at least did not agree or need a repeat ablation procedure. And again, we've seen this many times, but the Fire and Ice showed that the comparison of cryoballoon versus RF, which was problematic in this trial because the RF catheter evolved to contact force, and the ablation, the cryoballoon catheter evolved to the second generation Arctic Front Advance. But in general, there was statistically no difference. So when patients ask me what's better, I will tell them that the trials show that RF and cryo are comparable. As I've tried to argue, I think it's a more reproducible procedure, shorter procedure times, lower risk of some complications, including tamponade. And these trials ignore what happens in the blanking period. We use the blanking period importantly to really look at the benefit of the technology, but there are experiences that patients have in the first 2 months that we can't ignore, such as rehospitalization for heart failure, rehospitalization for recurrent atrial fibrillation, and early complications. So if you compare RF to cryo, in this Fire and Ice trial, there were 33% fewer repeat ablations in the cryo arm, 50% fewer cardioversions, 34% fewer cardiovascular hospitalizations, and 21% fewer all-cause hospitalizations in the cryo group compared to the RF group. And getting back to AF burden, so Dr. Andrade published the Circuit Dose trial, which was initially a trial to look at RF versus 2 formulas of cryo with 4-minute freezes versus 2-minute freezes. And overall, the outcomes were comparable. But what we learned from this trial that despite a success rate comparable to those other trials of about 70% at 3 years, what was striking was the reduction in overall AF burden. The AF burden was reduced by 99% in all these groups. That's the message I try to convey to patients and referring physicians. You know, we talk about the success rate, but I think we can also talk about reducing AF burden in patients, particularly patients with persistent AF. Other advantages, I think, of cryo. Here's a comparison of variability in based on experience or based on overall procedural volume. So these different colors depict procedural volumes of less than 100 AF ablation procedures per year, 100 to 150, over 200 or 500. With RF, the more ablation procedures you do, the better the outcomes. It seems to be more related to operator experience or procedural experience. The cryoballoon, on average, may be comparable, but you can see that there's much less variability from operator to operator. So I think that has somewhat democratized the ablation approach, but has also made it reproducible in terms of time and experience. There's some other important things that have been looked at. This is a paper that Rod Passman and Graham Pei published, and they're preparing now a validation cohort of this derivation study, looking at predictors of very late recurrences that include the presence of structural heart disease, coronary disease, left atrial enlargement, other signs of heart disease with left bundle branch block. Early recurrence of atrial fibrillation is a strong predictor of very late recurrences, and then non-paroxysmal atrial fibrillation we know has a higher rate of recurrence long term. Most of our group now is doing most of our cryoballoon and AF ablations with general anesthesia. I've kind of gone back and forth. Right now I do them almost all with general anesthesia, kind of eliminate some of those outlier patients who are difficult to sedate. I think the trigger for me was when the guy was moving around so much, his foot was hitting the fluoro control, so he was like going LEO, REO with his foot, and I'm like, you know, that's enough of this. But we had historical comparisons, and some of us still do moderate sedation. So Jeremy Wasserloff, who's now at Rush, looked at the experiences with moderate sedation versus general. There's a lot of data that RF ablation is dependent on contact force, and people will use general anesthesia. They'll use rapid pacing to stabilize the heart motion. They'll use jet ventilation. All those things seem to be important. For cryo, it doesn't seem to make as much of a difference. And they showed that although the time in the lab is slightly but significantly longer for general anesthesia, that's kind of obvious. They're going to be more monitoring and more time required to get the patients under general anesthesia. The outcomes are about the same, and the patient experience is actually interesting, about the same. So when we give moderate sedation and we're pacing the phrenic and the patient looks miserable, usually the next morning, they don't remember most of that. So I think that the options of general versus moderate are reasonable. Around the world, general anesthesia is very rarely used for AF ablations. In terms of overall complications, We talked a lot about complication mitigation yesterday, and we talked about RF compared to cryo. But I think that these data from the Fire and Ice trial have panned out. I think they're reproducible. I think although we now use vascular ultrasound to get groin access, the complication rates for getting 2 access sites for a double transeptal is a little higher. I think the atrial arrhythmias that patients have after RF, especially in the first 3 months after the procedure, are higher with RF compared to cryo. The main complication that's most, I hear some soccer. Is 1-0? Ah, those Dutch, man, they're just too tall. You can't run them down. It's like a really tall dog. You just can't chase it with a small dog. All right, so yeah, phrenic nerve injury is the main risk, and we really do everything we can to mitigate that with compound motor action potential monitoring. As soon as we get a freeze at about 60 seconds, I stop pushing to avoid pushing the balloon too close to the phrenic. Making sure that you're not too deep, getting an occlusive, getting an occlusion with the cryo balloon as proximal as possible before you start to freeze. Tamponade, I still think, is probably reproducibly higher with RF than with cryo, and the risk of stroke is quite low in both groups. Dr. Nair talked about vascular access yesterday. A point that I make that our 2 fellows in the room probably heard enough, but is that the artery is here and the vein is here, and you don't want to come straight down on the vein. You want to come in at an angle a little bit, because you're looking at the lumen of the artery here. There's also the wall of the artery. So you're not just trying to avoid that black stuff, you're trying to avoid the whole wall of the artery. So don't come down right by the vessel wall. You usually come in at an angle and access the vein at an angle. It's a nice example too of a nice little valve here in the femoral vein. This is a real life case. This is a 55-year-old woman with recurrent AFib in 2018, despite 2 prior PVI procedures with RF. We would like to think that this complication is no longer occurring in the world because we know better not to ablate with RF deep in the vein. But if you do, this is what you're going to see. This lady had significant pulmonary vein stenosis. The vein was as narrow as the sheath that's across the venogram. This is the most dreaded complication, is atrial esophageal fistula. This is a patient from probably 18 years ago at another hospital who died of an atrial esophageal fistula from RF. I think cryoballoon is safer on the esophagus, but if you're going to use RF, be super careful about avoiding esophageal injury. This was a study that we did just in terms of collateral injury and minimizing collateral injury. Nishant spearheaded this study. We have an interventional pulmonary team that was adjacent to our EP lab in the Bronx suite. So they agreed to come over and put a bronchoscope down, because I noticed that when we had the cryo balloon up here, we were very close to the airway. So this is the left main bronchus. There also, early on in the cryo experience, have been some reports of hemoptysis, and there are actually a couple of reports in the literature of, and I know of a case of an atrial bronchial fistula that can be a dreaded complication. But it shows you how we don't want to be ablating more than we need to. But with most cases, in the patients that we looked at with a bronchoscope, you will see ice formation in the airway, and you'll see a little bit of hemorrhage. So when a patient coughs up blood the next day, it's probably not from parenchymal injury to the lung, it's probably due to airway injury. It's usually benign, and when the pulmonologists saw this, they were unfazed. They said, oh, well, we put cryoprobes down the airway and we freeze the airway. So they weren't really too bothered by it. But I think it explains why some patients will have a chronic cough after a cryoballoon ablation for a few weeks, or will have some hemoptysis. But it's important to kind of always be looking at the tools that we have in preventing collateral damage. This is an example of how, getting back to the beginning of the talk, we need preventive therapies. We need to prevent atrial fibrillation. This is a poor guy who's had multiple ablations, multiple surgeries. It came back for left atrial flutter, and everything, as anybody in this room who's used a mapping system knows, everything that's red is low amplitude scar. The only remaining myocytes in his heart were here. And actually the flutter was dependent on this and terminated, and we just proceeded to ablate the very few remaining myocytes in his left atrium. We're not showing you the right atrium, but we do need non-destructive treatments for preventing atrial fibrillation as well. So I'll stop there, and I hope you have a great weekend. Any, 1-0 still? One nothing.
Any questions for Dr. Knight?
Yesterday I asked, but it was a biased group because they were at the cryo course, how many people here have not done a cryoballoon ablation? So most people have had some experience with it.
Experience. Yeah, so do you do anything about the cough at all, or no? Or do you see less of it now that you've recognized that issue, or not really?
I just remember one patient very well, and I don't think I really fully understood at the time what, I think it's just helpful to understand. They probably have some lesion in the airway, and I might have sent them to a pulmonologist. Maybe they can look down there and see if there's something they could treat, or I don't know what they would do, local steroids or something.
Yeah.
Yes.
Not necessarily doing a second freeze and cutting the duration.
Yeah, I mean,
Instead
especially with
of
the
2
first
4
generation
minutes.
balloon.
And also pushing. I don't think we, over time, have pushed as hard as we used to push.
Well, anecdotally, I have seen less of this problem of coughing, and I haven't had a patient with hemoptysis in a long time. So I think Dr. Michaud's right. We're much more willing to give a single freeze in the left upper vein if we get isolation within 40 to 60 seconds. I don't often give a second freeze. So I can remember at times, also, I think when we were less confident about what's isolation and what's not, we saw a lot of far field signals, and we didn't quite appreciate that the vein was already isolated. And I can think back to some cases where I probably froze the left upper vein far too many times.
Great. Any other questions at all? So, oh, yep.
I thought Fred had a question.
Have you seen any bronchial injury with RF ablation also?
Not with RF, not with RF. I have seen phrenic injury with RF, and so I would encourage you, if you're using RF and you're going around the right-sided veins, when you get close to the anterior structures, especially if you're near the carina, you should always pace at max output before you give RF. We did it for the PFA trials too, even though it's thought to be much safer. To be extra safe, we paced at the sites before we delivered PFA.
Yeah. But no, I want to make a comment about the cough, because it does happen with RF. The difference is now we are mostly using general anesthesia, but the day that we used to do that under conscious sedation, when you ablate the left superior, you do have people coughing, and some of the patients have chronic cough that lasts for several weeks after. So it's an irritation of the bronchial that, so it happened with both energy sources.
All right, why don't we go ahead and take a 15-minute break, and then we'll resume the program. Okay.
Got to come back.
Sparklight would have been supposed to think of it. Yeah, so that'll be the. So he was asking. You want to throw them in the hole? Is there our Scott?
Sending up selling it on eBay. The minute I get home, I'll show you those back to temperatures. That's cool. That's what it takes, right? Yeah. I and then shut it on there. So you were here about that. Yeah.
It's like 5 minutes before. Should we start now?
One question, okay. Can we, we're going to go ahead and get started. So I was just told that we have about 80 or so fellows also online. So I'm glad they've joined us, and welcome to all of you who are online, who are not here in person. For those who are online, please feel free to submit your questions via the chat, and we'll do our best to field those questions. So let's get started. Our next topic is persistent AF beyond the pulmonary veins from Dr. Natale.
Thank you, Amin. So those are my disclosure. Sort of the premise of a good success with what we do is to have good technology, but also an effective and safe procedure. So I think we're going to focus on what we think is important in making it effective beyond the pulmonary vein, and that's sort of one of the things that I mentioned. Maybe you're not exposed, or at least not all of you are exposed in their fellowship. So this is a study, the same way I think we are moving into first-line therapy for paroxysmal AF, and there are several studies that are published both with RF and cryo. I think the same trajectory is true for persistent. This is right now is the only study showing that first-line ablation is better than drugs. And this is an ongoing study that with Dr. Santangeli now at the Cleveland Clinic we've been doing for the last year. Enrollment is not easy, but those are important studies to sort of move the field forward so that the patient can get sooner to ablation. So I think you heard this already from Brad. So the rationale for PV isolation is that they are triggers, and I show you some example. But what we learn is that that is not the end of the story. It's true that the pulmonary vein are the main culprit for typical paroxysmal, because they are, there is a range of paroxysmal, and this is an issue with the current definition. But, and what are the other side? They're not random location. They're all associated by what we call the thoracic vein, under what we call the thoracic vein. So they are the pulmonary vein, the superior vena cava, the coronary sinus, the ligament of Marshall, and other, including the appendage. Even the appendage, if you look at the embryology, the proximal part, the smooth portion of the appendage is actually an extension of the primordial pulmonary vein. So they're all location driven by a common embryologic origin. So as I said, it's not random, but there are others like the low crista, the septum, that can, in some cases, become a problem. So what I want you to understand is that the philosophy of triggers is not just limited to the pulmonary vein. Okay. Obviously, when you move outside the pulmonary vein, because pulmonary vein isolation is now become a sort of anatomical procedure, it becomes more challenging because you need to actually decide where it is. So one first important thing that you need to realize, I see a lot of picture of fluoroscopy where you have one small catheter in the CS with 4 or 10 electrodes. That's not a good way to do non-PV trigger because you need more information. You need right and left atrial recording to understand where to focus. So that's very important. So, and then I have a question. Let's see what you say. What group used the term pulmonary vein isolation in a peer-reviewed paper for the first time? Let's see. What do you think? And this is an encouragement to read, not to just be on Twitter. We're almost there. So should we? Oh, okay. Maybe you guys read. So let's go. So actually, this is the first paper in 2000 from the Cleveland Clinic, where we publish and use the term pulmonary vein isolation. It was an ultrasound balloon that is not available anymore now. But this was the first peer-reviewed paper in 2000 where this terminology was used. And pulmonary vein isolation, people don't know, but we actually use a custom-made catheter made by a biomedical engineer from Case Western that was designed based on our specification to actually do this case. They were done in Italy. But this is the first paper. So sorry. Now, let's move. So this is how this evolved from pulmonary vein, and Brad mentioned from ostial to antral. Still today, the definition of antral is different. So in our lab, since the early 2000, antrum has been always the posterior wall for different reasons that include imaging, embryology, and anatomy. Imaging, we were the first user of intracardiac echo. If you use a phase array intracardiac echo, it's very obvious that the pulmonary vein extends posteriorly into a common ostium. It's much more common than what you see on a CT or by angiography, where by angiography, usually you miss this posterior extension. So This Antrum isolation was actually used by our group again to differentiate Antrum from ostial isolation. And people thought that the main reason was to avoid pulmonary vein stenosis, but actually we had data showing that improved success. This is a randomized study from Germany. This is again to show the difference between ostial and antral that has been found. So why posterior wall? And I want to show you this because there is a reason why you see all those lesions in the posterior wall. The box isolation that most people use is an ineffective procedure. So if you're doing a study to show posterior wall isolation benefit and use the box, you're doing something wrong because you will never be able to show a benefit because with the box isolation, you have a very high rate of reconnection that if you look at the literature is up to 80%. So there's no way you're going to show a benefit of a procedure where you have 80% reconnection. So the reason why we do it that way is because we tried the box and we've seen that by using the scatter plot, you have a very low chance of reconnection with a single procedure. This is, I think, in the order now less than 10%. So there is a big difference. Whereas by doing a box, you're going from about 48 to 80% reconnection. So make a very difference. This is the picture that I mentioned with eyes showing the posterior extension of the antrum. And it's very obvious that the dotted line as where the ostium was defined by angiography. So clearly eyes made us aware very early because we started using that in 2001 that we had to move more proximal. And then obviously the embryology, we've been saying that since again the early 2000 that the pulmonary vein, the posterior wall is an extension of the primordial pulmonary vein. So it's really naive to think that those trigger cells are only in the tube and they're not scattered everywhere, which is what we're seeing. And this is some early evidence in 2002 again from our group showing that if you do ostial and challenge patient with high dose of isoproterenol, you see a lot of more proximal triggers that disappear after you do posterior wall isolation. Other group is from NGH, surgical series. Actually, the surgical series by Damiano more recently show really a dismal success long-term by doing just PVI in patient undergoing surgery and surgical maze. So much stronger data from the surgical series. This is an example from Xian Chen group showing this posterior wall trigger scatter along the posterior wall in the SVC. How do we do it? We use what we call the roving lasso because those electrodes give you a higher definition. The endpoint is isolation. It's not just reducing the electrogram. That area of the posterior wall has to be silent. So if you put the lasso in the middle of the posterior wall, you see nothing. And if you pace, you don't capture. So that's really the endpoint. It's not just reducing the electrogram. Using the electrogram means no isolation. So it's very important. And in a randomized study where effective procedure are used to isolate the posterior wall, there is a benefit. This is with a convergent. And even the convergent has evolved to a procedure where they did the pseudo box to going across the posterior wall. If you see the top, let me see if I have this. If you see the top, well, I don't know, it's not working. If you see the top picture, all those blue, they are like serial linear lesion across the posterior wall. So even with the conversion, this has evolved to this rather than making a box around, which is what they did at the beginning, because by making a box around, even with the surgical approach, there was a lot of reconnection. So this idea of doing more is important and has been sort of realized also by the procedure. How to improve durability? I think that you heard some in the biophysics talk. One thing that is popular only in US because in Europe or in other countries, general anesthesia is a luxury, so it's not available. So they tend to do more with less. But actually, we show in this randomized study that if you use general anesthesia to really or high jet ventilation to increase stability, to reduce the motion of the diaphragm, you actually affect success and reduce reconnection at follow-up. Also, you all are using in practice contact force. This is one or two paper showing that the contact force improves success if you are able to maintain stable contact, 80% to 90%. In this paper, it was 80%. And you see here how success rate improve in those patients where the contact force was stable within a range that was set by the operator. So in this paper, it was 80%. In this other paper, was about 90%, again, showing the same benefit of having a stable contact force. So it's important that when you deliver energy, you are stable, because once you deliver energy and you cause edema, you might not have another chance to actually affect the tissue permanently. So it's very important. You heard about high power short duration. This is something that we've been using for a long, long time. Even before open irrigation came out, we used to use ice to drive power up until we see microbubble. I know many of you have read those papers. But what we do now, actually, this has changed from these slides that you see here, because we don't lower the power in the posterior wall anymore. And actually, I want to make a comment. We have a paper that was published a couple of years ago showing that in the posterior wall, if you reduce the lesion application to less than 10 seconds, because the temperature goes up, those are all area of reconnection. So you need to deliver high power short duration for at least 10 seconds to have a good chance of a permanent lesion. So in the posterior wall, when we cannot do that, we usually cool or deviate. And obviously, this is going to become a moot point with pulse field ablation. There will be no need to worry about this anymore with pulse field ablation. And you heard about the impedance. The one thing that I want to mention, the reason why we go above 40, you see here 45 to 48. If you use with irrigation up to 35 watts, you have a phenomenon that we describe in an animal study, which is called endocardial sparing because of the cooling. You need to really, with irrigation, you need to go at least at 40 watts to avoid endocardial sparing. That's an important message for those of you. In our lab, we call power setting of 35 or lower the sham procedure. So this is to give you an idea. And then this is to make the point of that we really don't require eye contact force. Actually, if you go to eye contact force, you really need to reset your power, because you increase the chance of steam pop, if you are around 45 or 50 watts. So you have to be careful. And you have to know your electrode, Tactica, smaller electrode, higher density current, as Susan mentioned, whereas the J&J catheter is a bigger electrode, so you have a little bit more freedom in going up with the power. Today, some of this is moot point because Medtronic has a diamond tip, J&J has a Q dot. Those are irrigation catheter with temperature-driven power. So you don't do anything. The system go up to a maximum of 50 watts based on tissue temperature down to 2-3 millimeter without you having to dial anything. So that's much more objective, but you still control the duration that I mentioned, at least 10 seconds, and the contact force. Those are important variables. So I'll show you this 59-year-old male with normal AF, normal left atrial side, paroxysmal AF. After isolation of the PV, he remained in atrial fibrillation. What would you do next? Then I'll give you this option. Okay, so good. It looks like the majority are going. So let's go on. So this is a meta-analysis that we published many years ago. There is no place in paroxysmal AF or even in persistent, but in paroxysmal AF, there is no place for empirical lesion. And this includes CAFE, linear lesion. So if you want to do something at that point, cardioversion and isoproterenol challenge to see if there is any other trigger is the best. Otherwise, you cardiovert and stop the procedure as long as you know that the pulmonary vein are permanently isolated. One benefit of isoproterenol, high dose of isoproterenol, is to actually favor reconnection. And the difference with the adenosine test, the adenosine usually does it for a few seconds, whereas with isoproterenol, when you reconnect, it stay there. There are caveats in the way you do it. So we learned that increasing the dose progressively reduce the amount of time you spend at high dose. So we go straight to 20 mics, sometimes 30 mics. That's what the way you should do it if you want to get more bucks from that challenging maneuver. So this is to show you, we look at many years ago, this is an abstract that actually Dr. Santangeli published when he was a fellow with us. Luigi was there too. We look at the so-called lone AF patient and look at the predictor of successful procedure with just PVI, and we saw that the failure rate increase based on some comorbidity that we all expect, so age, older people, female, more frequent hypertension, diabetes. But one variable that you need to ask your patient is duration. People that have a fib episode that consistently lasts more than 24 hours, those are people where you need to make an extra effort to look for non-PV trigger because they're kind of moving towards being persistent. So that's something that is important. And where are those non-PV trigger? This is the list. Obviously, I mentioned once the PV and posterior wall are isolated, because obviously in our lab, that is out of the picture. Otherwise, the posterior wall is obviously a source. You have coronary sinus, left atrial appendage, septum, then the crista, the SVC. So I'll show you a case here. 57-year-old paroxysmal AF referred to us after 2 failed PVI procedure, plus a right atrial isthmus ablation. Normally have mild LA dilatation, no structural heart disease. During mapping PV potential, we're seeing only in the left lower vein, it was one segment. Is that enough, or you would do something different? So let's vote. Yeah, I guess many of you got the gist. I think it looks like, okay. So as I mentioned before, already this patient had a right isthmus line, which we have shown in randomized study doesn't do anything to success, but everybody does it. There is no place in this patient for anything other than isoproterenol. So this is what the patient does on isoproterenol. So again, you need to have information. So you see a duodecapolar calyx that give you right and left atrial activation. Then you have a lasso in the appendage and another catheter in the septum close to the right pulmonary vein. So look at the sinus beat and the first beat of this drive, okay? Then I'm gonna go next. So based on the activation that you see there, what would you do next? Maybe can we put the slides again? Let's start voting. No, I wanted them to vote, but I want to show the tracing if we can. All right. Okay. Coronary sinus. Okay. Okay, I'm gonna move forward, okay. Okay, look at this again. I don't know, coronary sinus is, so what is the earliest? The earliest is on top. And I show you the picture where the catheter was, that is the superior vena cava. The activation is actually even more cranial than the sinus beats. The sinus beat earlier is like the mid crista. Here earliest is very high on the crista. So this is SVC. The CS is late, so there is no way that the CS has any role in this patient. Yes. No, it doesn't see the mouse, yeah. I don't know if, I don't have. Yeah, but it's not working, it's not working. Oh, there it is. So here, so this is sinus with the earliest here. This is the first beat, earliest up here, okay? So, okay, so we established that. So then this patient, as we watch, so this is the beginning, okay? Then we watch him kind of a little bit organized now into some sort of flutter, another flutter. So based on what you saw here in all this picture, what would you do? Okay, need more information. So we already show you that this started from the SVC. What more? So the point here is that once a trigger start a fire, you can have, based on whatever scar the patient, especially the redo procedure, you can have all kind of organized arrhythmia, flutter. So the focus is on the trigger. If you eliminate what start, the rest become irrelevant. Okay, so the trigger is in the SVC, so we start ablating the SVC. Look what happened. Now the patient is in sinus, and the SVC is still in fibrillation. Okay, this is for those that thinks about the critical mass. There is no critical mass. The SVC has like fused leaves of tissue that still can sustain atrial fibrillation. Okay, and Brad showed you before some pulmonary vein doing the same thing. So Fib can when I was a fellow with George Klein, those days, Gerard Giraudon, I don't know if you know who he is one of the giant of arrhythmia surgery, used to do the corridor operation. We saw patient having recurrence in the corridor. So it's like a narrow bridge of tissue that includes the sinus node and the AV node. Very small amount of tissue in sustained atrial fibrillation. So the SVC, as I mentioned, is a target. This is a randomized study from Europe that we are part of, showing that at least in paroxysmal there is a benefit. We cannot do it in everybody because it's very easy, but there are actually data in randomized studies showing that there is a benefit. Another case, 67-year-old male with persistent atrial fibrillation and 4 previous procedures. After the last procedure, he has developed persistent atypical flutter refractory to drug therapy. During the last procedure, activity was noted around the PV. No activity was noted around the PV in the posterior wall. The CT scan at the follow-up show something that I'm going to show you next. But what, based on this eyes picture, what would you do? How many in this room use eyes? Almost everybody. I think US there should be a standard. Yeah. In Europe, they have the excuse it's too expensive. Okay, so when you see something like this on ice, this is typical of only one thing, which is this: persistent left superior vena cava. When you see the large coronary sinus ostium, you see that only with this. When you see that on eyes, you need to think about that, even if you do not have a CT. Now, in this patient, we had a CT because it was a patient coming from another center, so we do the CT to make sure there is no pulmonary vein stenosis before we do anything else. But if you do not have a CT and you have eyes and you see this, this is typical. It's a marker. When you add that, you know that this patient has persistent left superior vena cava. And you see that the lasso is there. It's so big, and actually we put the lasso to target our ablation, because in these people, if you do not ablate the persistent superior vena cava, they will never be cured. They might have atrial tachycardia, more organized things, but so here you see the bunch of lesion that we deliver to isolate the structure. So let's move to another case. 84-year-old female with paroxysmal atrial fibrillation following PV and posterior wall isolation. Nothing, isotesting, right isthmus. Wow. I think this is Amin is voting. He knows that I get very mad when somebody mentions rotors. Yes, exactly, strolling. So isotesting, okay, good. I think, so as I mentioned, in both persistent and paroxysmal, there is no role. So this is to show you what I said before. You need information. As Brad showed you access with ultrasound, there is no risk in getting an IJ to put a duodecapolar. It's very stable. There is no way you're going to cause a lot of mechanical induced PSC when you give high dose of isoproterenol. That's a lot of contraction. And there is no risk. It's a single stick. You do it up in the neck. There is no absolutely, if you do it right, there is no risk of complication with ultrasound guided. So, and you have activation of the right and the left atrium. You have the appendage either by the far field from the left superior or because you put the LAS there. So you have a lot of information that can allow you to very quickly decide right or left atrium. In the left atrium where CS, anterior wall, appendage. So this is what we saw in this case. Remember, this is the set. This is the where we have the catheter, okay? This is the catheter position. And on isoproterenol, we see this. So the lasso is early, right? And then, as I showed before, then whatever happened after firing start is irrelevant because this patient then eventually go into AFib. So where is this trigger? It was the lateral appendage, obviously, because I showed. So we isolate, and then after isolation, the patient cannot go back in sinus. And so we isolate the appendage, okay? That's a situation that makes people more dependent on the blood thinner. So you need to talk to these people if you do it. If you don't do it, it's fine. But if you do it, you need to talk to these people and make clear that they cannot stop the blood thinner until you decide if they need a watchman to be safe or, we do that with TE. So this is the TE, a follow-up. So I'm gonna ask you, look at this TE, okay? I'm gonna ask you, based on the TE, is okay to stop the blood thinner because it looks normal or not? So I'm gonna put this vote. Okay. That's actually very, so the reason why I show you this, because this is a mistake that a lot of people doing TE do. You see that a waveform is actually normal by velocity, is above 50, but is diastolic, that's passive. The atrial contraction, which is the appendage, has to be after the P wave, not in the middle of the diastole. That's a passive mechanical. So this guy, actually, the question mark there is the appendage velocity, which is very low, is below 20. So this patient need to be on blood thinner or as a watchman. And this is something that if you want to read, is published in this paper that took us a long time to get published because every time we say that people read TE don't know how to read it, this raises issue. But this, believe me, this is a mistake that is done. I mean, we have patients that had this mistake made even in the best institution in the nation. So you need to know that. And it's very simple. You just need to make sure that whatever the people are measuring is after the P wave, between the P wave and the end of the QRS. Everything else in the middle of the diastole is irrelevant, that's passive. This one. Yeah. Yeah.
Until there's a forward.
Oh, forward, sorry.
Forward. Right here. So it looks like you've got sinus rhythm,
Yeah.
but the surface looks like it's still fibrillating. I wonder if you can record, we never see the pulmonary vein fibrillation, but I wonder if you can see
Yeah, you can.
fibrillation on the surface. Doesn't it look like there's still AFib on the surface?
No, so the first sinus beat is actually, you see the P wave there. So, so we have cases of appendage that was isolated in fib or flutter, where you see, you see some activity, but actually if you look at the beat, the first beat with sinus is the last one that you see, you actually see a P wave there. It's just kind of very bradycardic.
I wonder if you see fibrillation also, and you know what I mean?
It happens sometime, yes, it happens sometime, but it's very rare, I would say, yeah. So one thing that I want to talk about is this, additional empiric lesion, and those are mostly in area where there is an anatomical boundary, so typical flutter or perimetral flutter. So you mentioned that we show, this is a randomized study, actually we did the Cleveland Clinic, showing that in patients that have even clinical flutter, if you ablate the flutter, in addition to the PVI, there is no benefit, no increased success rate. And now they're actually serious, showing that even in patient with flutter only, if you isolate the vein, you have better outcome that when you ablate just the flutter. Because flutter is a manifestation of a fibrillatory symptom. There is no flutter. What do you do in the lab to induce flutter? You do burst pacing, you do fast pacing. This is what happens clinically. You have a short burst of AFib that organizes quickly into flutter. And I think the data are very much more clear now. There are several randomized studies in patients with flutter only. This is one of them that we did with a bunch of co-investigators, but there are 4 or 5 randomized papers. One just came out recently showing that in patients presenting with flutter, no AFib, yes, documented. If you ablate flutter versus do a PVI, you have much higher chance of freedom from arrhythmia long term, because flutter is just a manifestation of a fibrillatory syndrome. I think this is not in practice, but at least you had to discuss this with the patient. Tell the patient, listen, we're going to ablate the flutter, but this is probably the beginning of something that eventually is going to evolve. And actually, we published a paper many years ago showing that if you follow patients that had a successful flutter ablation long term, virtually all of them over a 5-6 year period come back with AFib refractory to medication. Another case, 46-year-old female with paroxysmal fibrillation at the 5 previous ablation at different institutions without resolution of her symptoms. She presented to perimitral. Actually, the physician referred to us told me, you might want to ablate the perimitral isthmus because that's what I think she has. And all the PV and the posterior wall were silent after the atrial flutter was terminated. So here's the flutter was terminated and you see that this patient already have, look at the CS, already have extensive ablation before. So again, is that the end? So what are you going to do next? By now you should know the answer. Yeah, it should be, let's keep it at 100%. That's good. So that's what we did. And this patient had this very, it looks kind of organized, obviously, because after all those ablation, firing. This was actually from the right side of the septum that, putting back out of the isoprotein. So, and we actually look at this issue of perimetral flutter. This is a randomized study of patients with persistent AF. They came with flutter, with recurrence. And on the table, if the flutter was perimetral, they were randomized to perimetral flutter ablation only versus non-PV trigger. And this is the difference. So if you do just a perimetral flutter, look at the recurrence rate. So it's completely, so if you want to do it, but don't stop there. That's really the message. So I think this idea, obviously this is the study F2 showing that CAFE linear lesion do not change success as compared to PVI. And one thing that I want to mention, beside the fact that the box approach is not effective to isolate the posterior wall, when we look at, so in this study, we actually remap the patient before we follow them up to prove that either the antrum or the posterior wall were isolated. But if we see here, the posterior wall is not isolated just between the vein, it's all the way down. We actually have data showing that a third the posterior wall trigger are actually in the bottom part. So if you do a box isolation beside You're not going to isolate the posterior wall. But also you are missing a third of the posterior wall trigger that are in the bottom part. So you're really making it very difficult to prove the benefit of this strategy. This is that paper. So non-PV trigger, this is a large study of close to 2,000 patients with persistent AF showing that if you have non-PV trigger that you are ignoring, the success rate in the green line is lower. The top line are people that have no non-PV trigger after the PVA posterior wall isolation, and the other one where the PV trigger were isolated. They have a similar success. The group where the non-PV trigger were ignored is the one with the worst outcome. And the reason why most of the non-PV trigger were ignored is because they were non-sustained. So this is another message. Non-sustained non-PV trigger is not something that you need to discard as not relevant. You might want to wait and see if, a follow-up, but then if you have those information recorded in your report, I think they will help you to do something for those patients. As I mentioned, the way we do it with isoproterenol, and as I said, we start at 20 mics for 10, 15 minutes. Don't do the ramp up because the ramp up give you less sort of benefit. I mentioned how do we locate. So again, the idea is more information, not only more information, but more information in a way that doesn't increase the chance of mechanically induced arrhythmia, because on 20 mics or 30 mics of isoproterenol, you have a lot of boom, 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 boom. So if you have contact force catheter, you're going to see a lot of mechanically induced things that are irrelevant. So you have to really use this sort of mostly floating electrode approach to be able to be effective. One issue that I want to mention, and this is something that, obviously is an evolving endpoint. So there are two areas where we've seen that the endpoint of isolation is important, as for the pulmonary vein, the superior vena cava, and one is the coronary sinus that you see here. You see here a trigger from there. Here is a blow up showing trigger. So we have seen that if we do focal ablation, they stop acutely the trigger. The long-term success is way lower than if you actually do isolation, which is clearly a more involved procedure, but paid off if you do it. So, and again, isolation, as with the posterior wall, means you see the coronary sinus on your left, on the right, you see nothing. You see just a far field V. So isolation means nothing. It doesn't mean, low amplitude recording. We do it, usually try to maximize endocardial ablation first before we go epicardially, so that we minimize the risk of problem. And there are ways to do it inside the coronary sinus safely. You have to remember that you are close to the coronary artery, so no long lesion, no more than 5 seconds, you move fast. Also make sure your catheter is never wedged anywhere. And still high power, we do. Otherwise we've seen, even with high power, by moving every 5-6 seconds, you have a significant reconnection with a single procedure. So, but do the most you can endocardially along the CS. And then the left atrial appendage is the other source that we described in 2010, showing that when that is a site for a non-PV trigger, isolation is the best approach, with the caveat that I mentioned in the case before in terms of follow-up. And this is a paper showing about 27% trigger from the left atrial appendage. And this is a large series of people with multiple failed procedure. So it's not like your first time, although we do the isoproterenol testing every time, but this is a group with multiple failed procedure where the pulmonary vein clearly were not the problem at that point, and we saw that about 27% had clearly something on the appendage. And I want to mention the majority of those were non-sustained. Okay, so this is important. History, another patient case. So 68-year-old, sleep apnea, obesity, diabetes, LA size of 5.2, previous ablation during which PV posterior wall and SVC were isolated. He is now has recurrence, no reconnection seen around the PV and the posterior wall. Next step. Well, I think now we're already at 100%. Yep. Okay, good. So again, in this case, again, you see that, so you should be familiar with the setup. So you have Krista, CS, appendage, and you see again another appendage trigger. Then you see you stop and then restart as we start the ablation. And then eventually, after isolation, you have what we call dissociated firing, which you see in the pulmonary vein, this we see in other area. It's actually much more common in the appendage than around the pulmonary vein. Usually it's low, as you see here. I want to mention the BELIEF is a study where we ran, in a randomized study where in long-standing persistent, we use empirical appendage isolation in addition to ablation of the other trigger. So I don't want you to think that the appendage is the magic spot. Is not. Is one of them, and you have to address all of them. If you just do that and you ignore other non-PV trigger, you're not going to be successful. And in the long-standing persistent, is always more than one. Okay. So we saw that there is a benefit. And this is published. Now, let me go quickly. People look at AMAZE as a negative study. First of all, AMAZE was a very rigid protocol because it was not even posterior wall. You could not even do isoproterenol tests. It was just PVI versus PVI plus ligation of the appendage with the lariat. Okay? As I mentioned, the appendage is one of the non-PV triggers. If you ignore the other one, you're going to dilute the benefit. Despite is sort of considered a negative study, when you look at the group of patients with left atrial dilatation, there was a benefit, okay? And this was a preset sub-analysis that was sort of part of the study design. So it was not just a post-hoc analysis. They actually designed the study to look at the group. So two caveats, a design that was not really optimized to show the benefit, but even by just doing only the PV, in the group of left atrial dilatation, there was a benefit by mechanically isolating the appendage with the lariat. The ligament of Marshall has been, so actually this is a study where we are part of. I have to tell you, there were 3 operators in our group that were part of the study. I was one and there are 2 others. None of us does this clinically. Why? The benefit is very small. What does so in the study we're supposed to do voltage mapping before and after injection. What the ligament of Marshall ethanol injection does, creates scar in the posterior wall and around the left pulmonary vein. So help the operator to do a better job with the left pulmonary vein isolation and the posterior wall. And in our lab, we don't think that, the extra time is worth it because we think we can do a good job by doing. So I just want you to kind of be aware that Miguel, and a proof of this is the first time persistent. We also did another study with this approach in REDO. And in the REDO study, which Miguel has not published yet, I'm not sure why, there was no benefit. Which kind of explain what I told you, that the benefit in the first time is actually in helping the operator with the posterior wall and the left pulmonary vein isolation. SCAR is another target that we actually published first, a tool, Verma was our fellow, published first in 2005. The SCAR is a predictor of failure with just PV posterior wall, but because severe, and this is severe scarring, because severe scarring is a marker that you need to go after non-PV trigger. Doesn't mean that the scar is a target, is that you need to focus on PV trigger. In fact, this is just to show that both in univariate and multivariate show that severe scarring was a stronger predictor of failure. Marouche, that also was our fellow, sort of went on using MRI to look at scar and sort of show the same things, severe scar equal to higher recognition rate. But when you look at the study where we try to target the scar as an extra site, they never show a benefit. This is a study that we published that was not randomized, showing that there's no benefit from PVA posterior wall. And the best benefit, the red line, was a non-PV trigger. This is from Spain, randomized, showing no benefit. And this is the DECAF2 showing no benefit. And this is a more recent study from Asia showing against no benefit from that. This is one study that recently showed benefit. But if you see here what they're doing posterior wall isolation. Actually, in the group randomized to without scar, that was randomized to having more ablation, which is posterior wall isolation, there was an 11% benefit. So the actual benefit of just doing what they call the scar is actually less than 10%. So you have to read very carefully this paper because it's very obvious that the benefit doesn't come from ablating the scar, but probably from ablating the posterior wall. So, and this is the SPO, you have to read. So this is my last slides showing kind of a summary of what I told you. It's all about triggers. The problem is that the word, our field has not evolved because we use, most of the center use a minimalistic approach. If you put one catheter, a quadripolar in the CS, you will never be able to do a non-PV trigger approach. It's impossible. So again, more information to drive to what I think is a more successful approach. Thank you very much.
I think we have time for a couple of questions. The update is the Netherlands are up 2-0, so it does not look good for
It was
us.
still the first half, right?
Dr.
While you guys are asking questions, I'm going to set up my
There
computer.
are two technical questions from the
Yes.
live people. So one of them is, what's your power and contact force to achieve SVC isolation? And the second one, which is in line with that, is how do you do the isolation of the persistent less superior vena cava? If you can give more technical
Yes.
information about power and
Power for the superior vena cava or for the CS?
for both.
For,
So the first one is SVC, contact force and power.
okay. So the SVC, we use 45 watts. And power, we always keep the power below 10 gram. High power, there is no need to go high contact force. Actually, if you use high contact force, you increase the chance of random problem. So
How to avoid phrenic nerve
So yes, so
during
that's,
SVC isolation.
that's a very good question. So obviously pacing, but we actually published a paper in Europace in patient where we could not ablate laterally. And if you actually, and there is a paper, a group from Japan that do high density mapping, there is a posterior input that is not lateral to the superior vena cava. So once you start coming posterior, instead of moving lateral, you just come down straight, and you're able to isolate the superior vena cava without getting close to the phrenic nerve. We still pace because very rarely the phrenic nerve can get, really more posterior, but it's much less common. So in that paper, actually, we were able to isolate most of those SVC, which we would not have been able to isolate by going lateral because of capturing the phrenic nerve with pacing. So pacing, obviously, but there is this sort of movie. So read the paper is, I think Carola Gianni is our fellow, is the first author in that paper. So read that paper and is being sort of reproduced by a group in Japan. In the CS and so in the persistent left superior, as I mentioned, we put the circular catheter. We start at the level of the left pulmonary vein, and then we move back proximally, and we really, you see those lesions, we want to isolate that area. When you are close to the left pulmonary vein, you have to pace because you can capture the phrenic nerve, so you have to make sure that you are not. But the end point is really using the lasso because it gives you a larger footprint than just the ablation catheter as you move around. To eliminate all the recording, we use 45 watts, as we use also in the coronary sinus, but as I mentioned, we move every 5-6 seconds. And we try to do, and that's very true when you are on the free wall. Also, you have to make sure you're not, in the persistent superior is not a major issue because they usually they have very small amount of branches, but in the real coronary sinus, you have to make sure that the catheter is free floating. So it's not wedged in any branch, because if you're wedged, then you can have, sort of problem with, coronary artery damage. And the 5-6 seconds is done to avoid that. Actually, when you start doing the CS, probably in the mid 2000, we had all those patients follow up with a CT angiogram to look at the coronary artery to make sure there was no problem. And by using the approach that I told you, moving every 5-6 seconds, we never saw any problem. When you sit down for a longer time, that's when you're looking for trouble. Any other?
Great. All right, we'll move on. So I think I'm the next speaker here. Yeah, I got it on. So, so my task is to talk to you about left atrial flutter in AFib ablation diagnosis and treatment. And I have to say I've had 4 or 5 cups of coffee, so I can try to match Dr. Kim's energy. But she did inspire me to add a couple of memes, so hopefully you'll enjoy them. These are my disclosures. So you just heard from Dr. Natali. And if you want to be like Dr. Natali, you can actually, purchase this outfit at Spirit of Halloween. It may be too late this season, but I'm sure it'll be back next season. It was a big hit in Austin. Okay, so here's a patient, flutter after ablation, now recurrent. Here's our EKG. Based on the EKG, can you tell me where the flutter is? Do you guys want to do a quick vote on this? Yeah, so I think this brings up the point that it's not easy, right? So I actually, looking at this EKG myself, I really wouldn't be able to tell you. There's a couple of reasons why. One, it's really hard to see the P waves. They're hidden in the T waves. You might be helped if you get a PVC and it uncovers things, but even if you do see the P waves, it's hard to make much out of them because a lot of times these patients have had a fair amount of ablation or they've had some scarring, and so it's not always easy to tell. So there's some overlap between right atrial and left atrial ECG sometimes, depending upon where the flutter is coming from. You can see isoelectric lines, even though you're not supposed to in flutter, you will see them after ablation or after surgery, and you may have low amplitude P waves as well. What about CS activation? CS activation can sometimes help you. So this is an interesting paper. This was from Cornell that looked at how the CS activation can help you with flutters. And so we're going to take a look at some of these algorithms as we go. One of the messages I want you to understand here is that not one algorithm works, whether it's P waves or looking at this or looking at that or looking at the map. You kind of have to put it all together. It's a little bit of a puzzle. Like you'll see with SVT ablation, you have all these things, all these inputs into you, and you kind of have to use them all. So CS activation helps, but it's not always the answer. Different tachycardia mechanisms, macro reentry in particular, if you make lines, so if you're making a mitral isthmus line or something like that, or a roof line, you may see more macro reentry. Localized reentry, which we tend to see near areas where you're unable to deliver very good RF due to contact force or due to short duration, like near the esophagus. Focal atrial attacks are less common, and then micro reentry and localized reentry are essentially the same thing, just very small areas of reentry that cause these flutters. This is from a paper from Sam Asirvatham, and a lot depends here on where you're making or what strategy you're doing. So if you do a strategy like Dr. Natali, you're not going to see this type of flutter in general. You'll see this more if you do lines or things like that. Our ablation strategy for these patients has always been the same. We do these on therapeutic anticoagulation, put an ICE catheter in. We typically put a 20-pole catheter in from the IJ, and I'll tell you why in a minute. We do double transeptal, and obviously we use a 3D mapping system. This is what it looks like. And so the advantage of this is a couple things. So the first advantage is it's extremely stable, meaning this catheter doesn't move. One of the biggest frustrations when you're doing a flutter map is that you've got the thing in the groin and the CS catheter slides back, and now your reference is gone and you have to do a remap. And so that happens from the groin. This never happens in the neck. The other advantage of this is you get a bigger span of electrodes. You have electrodes in the right atrium and the left atrium, so you cover more of the heart with this. So this is generally why I always do this for my atypical flutter ablations. Now, as your fellows and trying to get that catheter in, remember it's frustrating sometimes, not always that easy to get it in. I think it's a little easier to go from the neck, just another reason to consider that. But as you're trying to do it, you can see your attending just frowning at you as you're failing to get that catheter in.